my next case is a patient that was admitted to the hospital for lethargy that was noted by his family at home. They had trouble waking him up one morning. And so they brought him to the emergency department, and his oxygen saturation was 80%. And so he had a blood gas drawn, and you can see he has hypercapnic respiratory failure. And so he was admitted to the ICU and put on non-invasive ventilation. He was then diuresed and improved. It's notable that his BMI is 56. And so after that hospitalization, after that ICU stay, his blood gas improved. He remains a mildly bit hypercapnic, but his oxygenation is better now on room air with a PO2 of 60. And so in this particular case, prior to his discharge, they did a portable sleep test. Let me show you that on the next page. And then he was discharged. And he wasn't given any oxygen or PAP therapy at the time. And this is not that uncommon.
This is very, very uncommon, I can tell you. How was he discharged? And why does this happen? Without oxygen, no PAP, with that study?
Yes. So if you go back, remember his oxygen in the hospital now is 60. So he doesn't qualify for oxygen in the US.
Okay.
So he's not given oxygen. And
but they don't do an exercise test to check whether he's desaturating on exercise, considering he's on the border.
Yeah, well, they could have.
Sure.
It's possible. There are ways that they might have gotten him to qualify, but he didn't. He didn't get it. And he was discharged. And it's really hard to get PAP therapy in the U.S. At time of discharge.
But they did a type 4 study before he left, a type 3.
Right. So they did try to at least to get, so once he's out, they could maybe get him on therapy. So so here's a copy. So this is a WatchPat device. I don't know how commonly it's used in the places.
Is it something like an apnea link, or is it?
It's a little bit different, but it does have the most important signal, which is the oxygen saturation, which you can see.
Sure.
It actually scores breathing interruptions based on something called peripheral arterial tone.
Ah, okay. Yes, I've heard of
variability. So it uses an integrated algorithm along with the oxygen saturation. So this is kind of the most important panel. So it has an estimate of sleep, wake, REM, light sleep, deep sleep. And so, you can see it estimates right here, he's in REM. And then you can see the oxygen saturation while he's awake isn't bad. And then once he, drifts off into REM sleep, you can see there's some significant desats. He has a little awakening here, and then he has more REM. And then the rest of the night, when he's sleeping on his back, he has just recurrent oxygen desaturations. And so his overall AHI, based on this study, was almost 70. The oxygen saturation went to as low as 73%, and he spent almost 12% of the night with his oxygen saturation less than 88%. So this patient likely has obesity hypoventilation syndrome. Of course, that's defined by a BMI over 30 and a wake PCO2 over 45. And it's a diagnosis of exclusion, so you want to make sure they don't have other disorders that may be causing the hypercapnia. Most of these patients will have some abnormal lung function. Some of them may have developed pulmonary hypertension. The vast majority of them will have sleep apnea. And unlike obstructive sleep apnea, it has a similar prevalence in both females and males. Obesity hypoventilation syndrome has varied pathophysiology, which obviously starts with the fact that they are morbidly obese. They have impaired respiratory mechanics because of their obesity, increased work of breathing, and as I mentioned, most of them have sleep disordered breathing, both obstructive sleep apnea and sleep-related hypoventilation. They are thought to be leptin resistant, so they actually have high leptin levels, and that probably contributes to a problem with their respiratory drive. They may have trouble with respiratory muscle endurance because they have to work so hard to breathe all day long and all night long. And as mentioned, with the sleep disorder breathing, they can get hypoxemia and hypercapnia. Ultimately, these patients end up having low ventilation and hypercapnia, which occurs both at night and during the day. So going back to our sleep study the patient had, as I mentioned, you can see he has this little bit of REM period, a little tweak of REM here, and then goes back to non-REM sleep and then more REM. And you can see these spots right here are very important. And this is what I alluded to earlier, but this is kind of a combination of sleep apnea and REM-related hypoventilation. So sleep apnea causes this sawtooth pattern like you see here.
Right.
Repetitive oxygen desaturation, resaturation. So these are probably repetitive breathing events, obstructive breathing events. But what happens in REM is they're still having the obstructive breathing events, as you can see here. So there's still some of that sawtooth pattern, but the oxygen saturation is continuing to go down. So they don't recover from the baseline. And, you know, if you were measuring their CO2 at this time, you'd see that the CO2 is probably going up as well. So they have this REM-related, both obstructive sleep apnea and REM-related hypoventilation.
That's fascinating. I think that's such an important point to take home here.
So he does get back and has a PAP titration in the sleep lab. And most of these patients will do just fine with CPAP, but in this particular case, he was placed on bilevel to start. I wouldn't necessarily recommend that, but that's exactly what happened. So as you can see, again, getting back to the hypnogram. So he has a few, it doesn't show up very well, but he's having some hypopneas down here. And again, he starts right out in REM sleep. So he starts in REM, he goes right into REM sleep, which is often what you'll see when patients have severe sleep apnea and they go to sleep for the first time with a PAP machine on. It's like, oh my, let's right into. And
Right.
so they start out with a pressure of, it looks like 12/6. And he goes into REM, and you can see here's that 90% line. So immediately he starts to hypoventilate again and having events just like we saw earlier. So they go up on the pressures, and they get him up to a bit higher level during that REM period. And you can see now he finally starts to have improved ventilation.
Sure.
And then fortunately for us, back over here, he goes into REM again, which is really helpful.
Right.
And you can see now, you know, there's a few maybe events still going on, but he's now maintaining his oxygen saturation at acceptable levels.
Fascinating. The amount of information. Just to understand again, the watch pat also made out he was in REM or didn't have that information?
Yes, I'm going to go back. The WatchPat device itself has an algorithm that distinguishes wake, REM, light, and deep sleep. Now they're not measuring EEG,
okay,
but it's actually a pretty accurate algorithm, about 80% of the time. And oftentimes the REM is pretty obvious, like it is in this particular.
So that's a little bit of an advantage.
This is in a polysomnogram, so we know these are REM periods.
Right. But the WatchPat, that means, has that little advantage over the apnea link in determining that.
Yeah,
right.
Yeah, it does give you a little bit more information on sleep staging.
That's good. Super.
So, you know, with regards to obesity hypoventilation syndrome, if you take sleep apnea patients and match them by age to obesity hypoventilation syndrome patients, we know that those with OHS will have a lower quality of life, they have more healthcare costs, and they're much more likely, as I mentioned, to have pulmonary hypertension. They also tend to end up in the ICU more, and they tend to need mechanical ventilation more. If there's one point that, you know, I could make And this is an old study, but it's held up over the test of time. And if you can discharge these patients on mechanical ventilation or on non-invasive ventilation or PAP therapy, you reduce their mortality substantially. And so this is comparing patients with just simple obesity versus those with obesity hypoventilation syndrome that were hospitalized. And you can see those that did not get mechanical ventilation were much more likely to have a higher mortality.
Sure. Also, a lot of these patients just get NIV when they get discharged. And then of course the studies come later when they need specialist evaluation. They're often seen by internal medicine colleagues. They're put on an NIV. None of them are interested in doing a sleep study, and they go home with the NIV machine. And then when it comes to stopping the NIV or understanding it better, they land up in pulmonology clinics, and I think there's a lot in this data that we can learn from.
Yeah. Yeah, so there's been a lot of study around whether OHS patients need CPAP or need NIV. Right. And most of the studies show that CPAP is fine for the vast majority of them. If they have significant oxygen desaturation or that REM-related hypoventilation, some of those patients will benefit from NIV. But interestingly enough, even after like 3 months of therapy, a lot of them don't need the NIV any longer. They can go back to regular CPAP. But like I say, most of them just stay on the NIV because it's tends to be a little more tolerated and more comfortable for them.
And often they've bought the machine. So I guess the NIV machine can be fixed on a CPAP pressure as well, right? So
it could be. It's not going to probably hurt them to stay on NIV either. So I would say anything that makes them use their machine more is beneficial. So keep it on the NIV setting is probably okay if they purchased it and they're using it.
But I think far more patients than necessary get NIV rather than CPAP with OHS. So what percentage of patients would you say, Nancy, would do well with CPAP who have OHS?
I'd say 75-80% would be what the literature would support.
That's a lot. So there's a lot of NIV patients or NIV machines making good business there, but probably not actually indicated. That's very, very interesting. And CPAP machines are much cheaper than NIV machines. So I think that message should get across to pulmonology practices across the world.